So I want you to imagine kind of a structural paradox in the human body.
Okay, a paradox.
Right. Think of a canal where the opening can feel incredibly tight, like even painfully narrow. But then, just an inch deeper, the tissue has completely lost its support and feels entirely loose.
Yeah, that is definitely a paradox. It completely defies how we usually think about basic plumbing, you know?
Exactly. Because if you think of human anatomy like a simple uniform pipe where narrow at the top means narrow all the way down, this specific part of the body is going to completely break your logic.
And honestly, that linear thinking is a huge reason why so many people just suffer in silence. I mean, we are dealing with an area of anatomy that affects literally half the global population, but it is almost never discussed with any real biomechanical honesty.
Which is exactly why we're here. Welcome to the deep dive. Our mission today is to pull back the curtain on the pelvic floor, vaginal laxity, and pelvic organ prolapse.
It's a heavy topic, but so necessary.
It really is.
Yeah.
And we're zeroing in on a question that, like we said, sounds biologically contradictory at first glance. Can the deeper vaginal canal actually feel unsupported and loose while the opening feels completely tight?
Spoiler alert for everyone listening, yes, it absolutely can.
Right. And understanding the actual mechanics of why that happens will honestly fundamentally change how you view female anatomy, physical trauma, and recovery.
To get to the bottom of this, we are synthesizing some pretty dense material today. We've pulled from advanced urogynecology textbooks, some really fascinating new original research from Frontiers in Medicine tracking postpartum tissue damage, and of course, the comprehensive clinical guidelines on GSM, which is the genitourinary syndrome of menopause.
So let's jump right into this central paradox, because to answer how the opening can be tight while the inside is loose, I basically had to completely unlearn what I thought I knew about the shape of the vagina.
Yeah, most people do.
Right, because the medical literature makes it very clear that this is not a PVC pipe. We need to visualize something much closer to like a funnel.
A funnel is a great analogy for the architecture. But to really get it, we have to look at the construction materials, so to speak.
Okay, break that down for me.
Well, the opening, which anatomically is called the introitus, is essentially the mouth of that funnel. But the deeper canal is supported by an entirely different structural system, specifically the mid-vagina levator region.
That they're separate.
Completely separate. And the key to this entire paradox is that these two areas are controlled by entirely different independent muscle groups.
Wait. Let me make sure I'm picturing this correctly. Are you saying that the muscles that control the entrance don't actually connect to the muscles doing the heavy lifting deeper inside?
That is the core of it, yeah. The introitus, that opening, has its own superficial musculature. And these are muscles that can involuntarily spasm or tighten in response to pain or trauma.
Which is a condition called vaginismus.
Exactly, vaginismus. Or, the tissue there can simply become rigid due to stenosis. So you end up with this narrow, highly reactive gateway. But once you pass that gateway, the deeper canal sits right in the hammock of the levator ani muscles. Because these systems are distinct, a person can absolutely present with a restrictive, tight opening while simultaneously experiencing severe vaginal laxity just a few centimeters deeper inside the canal.
Wow, that just blows my mind. The gateway is closed, but the house behind it is collapsing.
That's a really stark way to put it, but yeah.
But okay, before we dig into why that house collapses,
Yeah.
I have to push back a little on this whole concept of quote-unquote laxity and what we even define as normal.
Fair point.
Because our sources point out that vaginas naturally expand from like 3 to 4 inches deep to 4 to 8 inches deep when aroused.
They do, yeah.
And they change width dramatically too. So if we're talking about an organ literally designed for extreme physiological shape-shifting, how can clinicians even quantify when it has become too loose?
The medical community actually wrestles with that exact terminology a lot. To separate healthy expansion from pathological laxity, we essentially have to slice the tissue open, conceptually speaking, of course, and look at the layer.
Conceptually.
So the innermost layer is the mucosa. It's lined with these brilliant accordion-like folds called rugae.
Rugae.
Yeah. And these folds are the secret to that extreme shape-shifting. They unfold to allow the tissue to stretch massively without tearing.
So the rugae handle the stretching.
They do. But beneath that mucosa is the muscular layer, and then, crucially, the adventitia layer.
The adventitia.
Right. And the adventitia is incredibly rich in collagen fibers. It provides the actual structural scaffolding. It dictates the physical limits of the stretch and basically snaps everything back into place.
Okay, I think of it like the rebar inside a concrete pillar. Like the concrete gives it shape, but the rebar gives it tensile strength so it doesn't just crumble under weight.
That works perfectly,
Yeah.
yes. So when we talked about vaginal laxity in a clinical sense, we are usually talking about a subjective feeling of looseness reported by the patient.
Which is often accompanied by a loss of physical sensation, right?
Exactly. And this happens because that adventitia layer, your rebar, has lost its structural integrity. The scaffolding is compromised.
Got it. And we really need to draw a hard line here for you, the listener, between laxity and pelvic organ prolapse. Because they're related, sure, but physically very different things.
Extremely different. Laxity is the loss of firmness within the walls themselves, but pelvic organ prolapse is a physical hernia.
A hernia.
Right. It occurs when the connective tissue and ligaments supporting the entire region literally break or detach. And when that support gives way, neighboring organs like the bladder, the rectum, or the uterus, they basically collapse and drop down into the vaginal space.
Which makes sense. I mean, if the pelvic floor is this multi-layered hammock of muscles and collagen scaffolding, it would take an immense amount of physical force to actually break it. Which I guess brings us straight to the biomechanics of childbirth.
It does, and the sheer physics of vaginal delivery are staggering when you look at the skeletal muscle data.
Yeah, that Frontiers in Medicine study we reviewed on postpartum women was intense.
It really was. They measured the distension required for a fetal head to pass through. The levator ani muscle, that deep hammock, we discussed it, has to stretch to a degree that would catastrophically rupture almost any other skeletal muscle in the human body.
I was reading those statistics and having a really hard time wrapping my head around the scale of the damage. We aren't just talking about being a little sore.
Not at all, not even close. The data shows that 15% of women who deliver vaginally experience macrotrauma.
15%.
Yeah. And in urogynecology, macrotrauma specifically refers to a levator avulsion.
Which
It means the muscle is physically torn off its attachment point on the pubic bone.
torn completely off the bone. 15%. That is a massive portion of the population walking around with a detached pelvic muscle.
It's a huge number.
And the study highlighted that another 21% experience microtrauma. So what exactly distinguishes microtrauma if the muscle isn't physically ripped off the bone?
Good question. Microtrauma refers to the irreversible overstretching of the levator hiatus. So the muscle stays attached to the bone, right? But the fibers themselves are stretched beyond their elastic limit.
Like the rebar is permanently bent out of shape.
Exactly. The rebar is permanently bent.
So over a third of women who deliver vaginally walk away with permanent structural changes to their pelvic floor. But what I found absolutely fascinating in the Frontiers study was how they tracked the weight of the baby against the risk of this damage.
Oh, the threshold effect.
Yes, they discovered this phenomenon they called a threshold effect. For posterior wall prolapse, which is when the rectum bulges into the back of the vagina, creating a rectus falling, the risk shoots up by an astonishing 71% for every single kilogram increase in the baby's birth weight.
The acceleration of risk is immense there, but the study uncovered a massive caveat to that statistic.
Right, the risk goes up by 71% per kilo, but only until the baby hits 3.7 kilograms.
Exactly.
Once the birth weight crosses that 3.7 kilo line, the risk curve just completely flattens out. A 4.5 kilo baby doesn't seem to cause exponentially more damage than a 3.8 kilo baby. I need you to explain the physics of this to me.
I can definitely do that.
Are we saying that once a baby hits 3.7 kilograms, the pelvic tissue has essentially reached its maximum stretch capacity, and a heavier baby just doesn't do incremental damage?
That is the exact biomechanical reality of tissue stress saturation. Think of the levator ani and the fascial tissues as having a maximal tensile threshold.
Okay.
Up to 3.7 kilograms, the tissue is absorbing the increasing load, stretching thinner and thinner, and the risk of tearing skyrockets. But around that 3.7 kilogram mark, the supportive structures reach their absolute limit. The structural breaking point is crossed.
Oh, I see. It's like pulling a thick rubber band. The tension builds and builds, it gets harder to pull, but once it finally snaps under the strain, taking the two broken ends and pulling them further apart doesn't make the rubber band more snapped.
Right.
The structural failure has already occurred.
That captures the mechanics perfectly. Further increases in fetal weight, add volume and load, sure, but they don't result in significantly more incremental tearing because the fascia has already yielded.
Wow.
And the study dives into why the posterior wall, the back wall near the rectum, is so incredibly vulnerable to this weight compared to the anterior wall near the bladder.
Because the back wall is basically taking a double hit during the delivery.
Exactly. It endures dual traction forces. As the fetal head rotates during descent, it drags against that posterior wall, creating shear stress.
Oh.
And simultaneously, the posterior compartment is taking the absolute brunt of the downward intra-abdominal pressure. The anterior wall on the bladder side gets a physical shield.
The bone, right.
Yep.
The pubic symphysis. It's a rigid bone at the front of the pelvis, and it helps disperse a lot of that mechanical stress away from the bladder supports.
It really is a phenomenal feat of human engineering, even when it fails. So, okay, we've established how mechanical trauma from a 3.7-kilo baby can permanently break the collagen scaffolding.
Right.
But that mechanical explanation leaves a pretty massive gap in the data. The textbooks state that 50% of all women over the age of 50 experience some degree of prolapse.
50%.
Half of all women.
Yeah.
Including women who have never been pregnant or given birth. So if mechanical trauma didn't rip the muscle off the bone for them, what is degrading the scaffolding for everyone else?
Well, the culprit behind that statistic is entirely hormonal.
Yeah.
We are looking at a systemic condition known as the genitourinary syndrome of menopause, or GSM.
Correct, GSM.
To grasp how devastating GSM can be to the pelvic floor, we really have to zoom in to the cellular level. Estrogen is not just a reproductive hormone, you know? It is a vital chemical messenger for tissue maintenance.
Estrogen receptors are densely packed throughout the bladder, the urethra, the vagina, and the pelvic floor musculature.
So it's acting like an active maintenance signal.
Precisely. As long as estrogen is present, it signals the fibroblasts, which are the specific cells responsible for creating collagen, to keep producing. It keeps the tissues thick, highly vascularized, and elastic.
But then menopause hits.
Right. During perimenopause and menopause, when estrogen levels plummet, that entire cellular ecosystem basically goes into shock. The maintenance signal is turned off.
So what happens to the existing architecture when the signal just vanishes? Does the collagen just dissolve?
It doesn't dissolve, no, but it fundamentally transforms. Without estrogen, the fibroblasts go dormant. The existing collagen fibers within the dermal layer literally fuse together, and the elastin fibers begin to fragment.
Yikes.
The tissue physically changes from a dynamic, stretchy net into this rigid, brittle state.
And the visible effects of this are stark. Our sources describe the vaginal epithelium becoming pale and friable, which means it tears easily under even minor friction.
Extremely easily.
And those brilliant accordion-like rugae we talked about earlier, they completely flatten out and disappear.
And the physical thinning of the tissue is really only half the crisis. It actually triggers a chain reaction that completely alters the vaginal microbiome.
How so?
Well, in a healthy, estrogen-rich environment, the natural shedding of epithelial cells releases glycogen. That glycogen is the primary food source for good bacteria called lactobacilli.
The lactobacilli, right?
Yeah, and they produce lactic acid, keeping the entire environment highly acidic, which is the body's natural defense mechanism against infection.
But when the estrogen drops, the epithelium thins out, the glycogen supply dries up, and the good bacteria basically starve to death.
Which causes the pH of the vagina to swing dramatically from acidic to alkaline. And the clinical guidelines literally compare this postmenopausal alkalinity to caustic soda.
Caustic soda. I mean, if you are listening to this and you've ever wondered why recurring urinary tract infections suddenly become a constant maddening companion in your late 50s, this is the hidden architectural reason why.
Absolutely.
That alkaline environment is just rolling out the red carpet for commensal organisms like E. coli to migrate from the gut and take over the urinary tract.
It creates a vicious cycle of infections and tissue irritation. And if we connect this systemic hormonal failure back to our initial paradox, the vagina feeling loose and tight at the same time, the loss of estrogen explains the final piece of the puzzle.
Because just as the pelvic muscles are naturally losing their bulk and strength purely due to the aging process, the connective tissues, the fascia holding everything up in the pelvis, are simultaneously losing their estrogen-fueled elasticity.
Exactly.
The scaffolding becomes brittle just as the hammock gets weaker.
It is the absolute perfect storm for a prolapse. The supportive ligaments at the top of the vagina, which suspend the uterus and the vaginal vault, begin to sag under the weight of gravity.
Okay.
This allows the pelvic organs to descend, and this creates a deeply confusing physical sensation for the patient. You develop a physical bulge from the descending bladder or rectum, That bulge ironically makes the vaginal canal feel incredibly full, heavy, and compressed.
Even though the vaginal tissue itself has completely lost its structural elasticity
Yeah.
and is suffering from laxity.
Yes, exactly.
You have a vagina that physically feels loose, unsupported, and lacks sensation because the collagen is fragmented, but it simultaneously feels heavy and bulging because an organ is literally falling into the space.
It's a horrible paradox.
That sounds incredibly distressing to experience, especially if you don't understand the underlying mechanics. So knowing all these vulnerabilities, the 3.7 kilo threshold for mechanical trauma and the cellular collagen fusion from menopause, what can actually be done?
Well, to address treatment properly, we have to separate biomechanical realities from popular myths. And the most pervasive myth in conservative management is the idea that Kegel exercises can fix everything.
Oh yeah, just do more cake.
Calls.
It is the universal advice handed out for basically any pelvic complaint.
Always.
But I want to bring in a brilliant analogy from our source material because it completely reframes why Kegels often fail for prolapse patients.
It's a great analogy.
Trying to fix a severe prolapse, which we've established, is a physical break in the fascial connective tissue with only pelvic floor muscle exercises, is like doing sit-ups to cure a belly button hernia.
That analogy highlights the anatomical truth perfectly. You can strengthen the underlying muscle layer all day long, but no amount of repetitive flexing is going to magically bridge the gap and put torn connective tissue back together.
Right. If the levator ani is torn off the pubic bone, flexing the remaining attached muscle isn't going to somehow reattach the severed end.
Exactly. Pelvic floor muscle training is excellent for improving baseline muscle tone, it is highly effective for managing urinary incontinence, and it provides a thicker base of support overall.
Sure.
But if the pubocervical fascia has a physical rupture, allowing the bladder to drop through, a muscle contraction cannot sew that rupture shut.
So if Kegels aren't the magic cure-all for a broken scaffolding, what are the actual interventions? If we start non-surgically, the sources point heavily to pessaries.
Pessaries are fantastic. A pessary is a flexible, typically silicone device that a clinician places directly inside the vaginal canal. Its function is purely mechanical.
Okay, so how does it work?
It acts as a physical replacement for the weakened or torn fascia. It physically props up the descending organs and holds them in their correct anatomical position. They come in dozens of shapes, rings, cubes, dishes, and for many patients, simply inserting the pessary completely relieves the dragging, heavy sensation of prolapse without requiring a single incision.
That's incredible. But if patient's prolapse is advanced, or, say, a pessary isn't viable, surgery becomes the focus. And here, our sources draw a very aggressive line between traditional reconstructive prolapse repairs and what is marketed as cosmetic gynecology.
It is a critical distinction that patients must understand. Traditional prolapse repairs, like an anterior colporrhaphy for a dropped bladder or a posterior colporrhaphy for a dropped rectum, are reconstructive engineering.
So what is the surgeon actually doing?
The surgeon's goal is to dissect the tissue, locate the broken, retracted edges of the native fascia, and stitch those specific edges back together. They are rebuilding the structural wall to keep the organ in its proper compartment.
Got it. Whereas cosmetic gynecology repairs, often marketed as vaginal rejuvenation, frequently focus purely on reducing the caliber or the diameter of the opening.
Right. They often just tighten the superficial perineal muscles at the introitus. And if you think back to our tight opening, loose canal paradox, you can see the danger here.
You are artificially creating the paradox.
Exactly.
If a surgeon just cosmetically tightens the entrance, they haven't done anything to fix the heavy bladder falling through the broken fascia deeper in the canal. You've just built a smaller doorway to a collapsing room.
That's exactly what happens. And for severe advanced prolapse, where the very top of the vaginal valve or the uterus itself is descending, simply fixing the walls isn't enough. Surgeons have to look higher up in the pelvis and perform ligament suspensions.
The text mentions sacrospinous ligament suspensions and uterosacral ligament suspensions.
Yeah.
What does that actually look like in practice? How do you suspend an organ?
Think of the vagina like a tent.
Okay, a tent.
If the main pole holding up the center of the tent snaps, the whole structure collapses inward. A suspension surgery uses the incredibly strong, deep pelvic ligaments, like the uterosacral ligaments near the spine, as new anchor points.
Oh, wow.
The surgeon uses permanent sutures or biological grafts to literally hoist the top of the vagina back up to those deep ligaments, reestablishing what we call level 1 anatomical support.
So you are physically tying the top of the tent back to the structural beams of the pelvis.
Basically, yes.
And then, There is an intervention mentioned in the clinical guidelines for patients who have severe, debilitating prolapse but no longer desire penetrative intercourse, a colpoclysis.
Colpoclysis is a highly effective obliterative procedure. Rather than trying to rebuild complex, weakened fascial walls, the surgeon removes the mucosal lining and physically sutures the front wall of the vagina directly to the back wall.
Wait, so they're essentially collapsing the tent on purpose and sealing it.
Yes, it creates a solid biological blockade that permanently stops the pelvic organs from falling down.
That's fascinating.
It is. Because it doesn't require deep pelvic dissection or anchoring to ligaments, the operative time is very short. That makes it an incredibly safe, durable option for elderly patients who might not survive a 4-hour reconstructive surgery. But of course, it permanently alters vaginal anatomy and function.
Which highlights just how deeply individualized this care has to be. Let's summarize this journey for everyone listening. We started by tackling that impossible structural paradox. How can the vaginal opening feel painfully tight while the deeper canal feels unsupported and loose?
Right.
And we learned it's because the gateway and the inner hammock are controlled by entirely different muscle groups, the introitus versus the deep levator ani.
Exactly. And then we explored the incredible biomechanical trauma of childbirth, discovering that the pelvic tissue hits a stress saturation threshold when a baby reaches 3.7 kilograms. After that weight, the rebar is essentially fully compromised.
And we unpacked the silent systemic shock of menopause, where a drop in estrogen fundamentally starves the pelvic floor of its collagen maintenance signal. The tissue becomes brittle, the folds disappear, and the entire pH of the region shifts to an alkaline state that basically invades chronic infection.
The overarching takeaway from the medical literature is that while these structural failures are incredibly common, affecting half the population, they are driven by identifiable biomechanical and hormonal mechanisms.
So,
They do not have to be endured in silence as just a normal part of aging.
absolutely. There are real tangible solutions. But before we wrap up, I want to leave you with one final, deeply intriguing piece of research to ponder.
The Manzini study.
Yes. We talked extensively about pessaries, those silicone devices used to just passively hold the prolapsed organs up like a mechanical crutch. Well, our sources highlighted a recent study by Manzini et al. That monitored women using these passive devices over time, and they found something that challenges our whole understanding of pelvic floor recovery.
It was a remarkable finding. By simply using a pessary to restore the proper anatomical position of the organs, the researchers observed actual functional changes. The active contractile strength of the puborectalis muscle measurably improved.
The muscle function improved passively just by taking the constant weight off the compromised tissue.
Mm.
Which leaves us with a thought for you to carry forward. If a simple passive support device can actually signal your pelvic muscles to behave differently and begin healing, what else might we discover about the hidden regenerative power of the human pelvic floor? If we just started talking about the biomechanics openly, maybe it's finally time we throw that basic plumbing manual away for good.